Have you ever wondered how biostasis works? Let us guide you through it. Medical biostasis is an advanced technology that aims to give you the best chance to live much longer than what is currently possible. But why do people want to live longer? Some people just love life and want to experience it for as long as possible. Some people are just curious about the future. They want to see what future cities will be like and what humanity will be able to achieve. Others think the world would be better and more fair if the length of your life was your own choice. There is no doubt that you will ever run out of things to do in a multifaceted world like the one we live in. In the end, the motivations are plentiful. But how can someone sign up for biostasis? First, you simply sign up with us and our insurance partner. It just takes a few minutes. To start, we only need some personal information. Don't worry, it's a simple process and we will guide you through every step of the way. Biostasis is achieved with the help of cryopreservation. Cryopreservation is a very advanced procedure that's still rather expensive and therefore not widely available. Tomorrow offers high-quality cryopreservation with prices starting from €100,000 and going all the way up to €400,000. Of course, this is a lot of money that few people can easily afford. But there is a solution. Together with our big-term life insurance partner, we offer a subscription model which brings the cost down to only €30 a month. About 90% of all biostasis contracts are funded via a term life insurance model. Let's say you're 30 years old and you want to sign up. The first thing you need to do is sign up with Tomorrow Biostasis, and we automatically contract with our term life insurance partner for your coverage. Now, should you pass away during the coverage period, the term life insurance will cover 100% of the cryopreservation cost. You are protected from day one. Should you pass away after the coverage period, then unfortunately the term life insurance will not cover the cryopreservation cost. But of course there are other funding options for this situation as well. We make sure that our customers have everything in place well in advance. Furthermore, there is a high chance that prices will come down significantly in the future, as we work consistently to reduce the cost of a high-quality cryopreservation. Congratulations! You are now fully signed up. Now, should anything happen to you where current medical technology can't save you, like a terminal heart disease, cancer, or whatever it might be, and the worst case happens and you should die, our team stands ready to pick you up and bring you to a medical research institute that is equipped for cryopreservation. Cryopreservation is an advanced procedure that uses medical cryoprotectant solution and very low temperatures to protect your body, and most importantly your brain, the part that makes you, against degradation. We keep you safe and sound for however long it takes until medical technology will be advanced enough that revival is possible. While we can't guarantee, that is arguably better than any other option. Then, once technology makes it possible, we will revive you. Should you have gotten cryopreserved at an old age, then revival will only be done once rejuvenation technology is available and the human lifespan is much longer than it currently is. Sometimes people are worried that life in the future might not be as enjoyable as it is today. But if history has shown us anything, it is that the average quality of life keeps getting better during the years. Now, after revival, you are free to continue your life as fit and happy as ever. Of course, this is a complex topic where a short video doesn't really do it justice. We are more than happy to answer any questions you may have. Just reach out to us. Find out more.
Welcome everybody to our Tomorrow Bio webinar, the 11-part series about covering cryopreservation literally from A to Z. Today, the topic will be procedures and SST. If someone has missed the last Welcome back one more time to our Tomorrow Bio webinar, where we cover cryopreservation from A to Z. Today will be about procedures and SST. For those of you who have not met us yet, let me give you a quick introduction. Who we are, how I am. Tomorrow Bio is a cryopreservation organization based here in Berlin, in Germany, with a long-term storage facility in Switzerland, close to Zurich. I'm a medical doctor by training. I've been always involved in the longevity space, have been doing a few other tech companies, and now I'm the founder and the president of the board of these two organizations doing cryopreservation in Europe. For now, later on, we will also expand to the US, of course, and very importantly, we're very much working on making cryopreservation better, increasing quality, and communicating the topic more openly, being more open to, to answer questions, and kind of doing education in the space of cryopreservation. Today, as I already said, we're in the second webinar. A couple of weeks ago, we did the introductory webinar, kind of very general about cryopreservation and cryonics in general. Today will be about procedures in SST. And as you can see here on the screen, there will be another 9 webinars for a total number of 11, covering literally everything that is interested in the topic. So one quick thing, currently we have all the webinars scheduled every 2 weeks. If you prefer to have them every week, kind of, to get through the whole list faster, please right now either in the YouTube chat or more precisely, I think YouTube chat would actually be the best. Let us know if you would like to keep it on an every 2 weeks frequency, or if you want to have it faster with one webinar every week. Right, now without further ado, as I said, we're covering procedures and SST. For all the topics, I will give an introduction kind of for, let's say, half an hour or so. And then it's very important for me to answer all questions that you might have. We have 2 ways of how you can ask questions. One is in YouTube chat, just write them in YouTube chat. And then here with the QR code that you see, or if you go to the webpage sli.do and enter this number that you see on your screen, there will be a form where you can ask questions. You can not only ask questions, but you can also upvote them. And if we're running out of time, we will focus on those questions that have the most upvotes, and we will start with the ones that are on Slido, because there upvoting is possible, and then go second for questions that are in the YouTube chat. So ask questions, anything and everything about the topic, and I'm more than happy to answer in the end. All right, today we talk about procedures and SST. So when we think back of how the whole cryopreservation procedure works, where initially, of course, people, once they have informed themselves about the topic, sign up, put funding in place. Now, if anything happens to them, then procedures at SST would be the first part where our teams really get involved with a member. Kind of the emergency part where we need to make sure that as quick as possible the cool down and cryopreservation procedures are being started. And then the next steps there would be after that would be the actual cryopreservation at the facility, and then the long-term storage and potentially revival. So this is kind of where we are in the overall process. Now, the SST part kind of divides itself into multiple steps. First, it would be first aid, right? Basically the initial response, making sure that there's a medical team on site, that cooling starts as quick as possible, and so on. So everything that allows us to reduce ischemia as much as possible. Ischemia means the time where the body, and most importantly the brain, is without oxygen. So the time where cells die on a cellular level because they don't have oxygen. Reducing that time, and not only reducing the time of that ischemia, but also reducing the impact of ischemia. Now, this first aid is kind of usually in combination with what is called standby. In fact, usually standby comes before that. The only reason why we have first aid kind of separated as an individual, like first pillar step, is because the first aid part can, in theory, can be done by local volunteer teams and does not necessarily need to be done by a professional team. So first aid and standby can either be local or done professionally. Usually, of course, standby is done by our teams. So when we're being notified that someone might die in the next days or weeks, we send one of our teams to the patient, to the member at that point, and then that team waits around and then is directly on site should the patient be declared dead. So standby is a very, very crucial point, right? You will see in a second Europe and the world for sure, but also Europe is definitely too big so that a team can be with the patient from wherever they are, let's say from Berlin, in our case, can be with the patient very quick if they're only being notified last minute. So it's very, very important for us that we're being notified that something might happen as soon as possible so that we can deploy, put our teams on the ground, have our teams in quotation marks waiting around so that we can directly jump in. Then after standby would be stabilization. Stabilization practically means that you want to keep the body in a condition as if the body should be revived, right? So you want to give oxygen, you want to give chest compressions, you want to keep the cells from dying, and at the same time you start cooling. In most cases, we do that in our ambulances, in our local ambulances. I'll show you some pictures of that and how that works in a second as well. And then once the whole stabilization process is done, which in our case, if you do field cryoprotection, which we do, I'll talk more about that in a second as well. In that case, the whole perfusion is also being done on site. And then last but not least comes the transport part, which basically just means transporting the patient as quick as possible back to the cryopreservation facility for then further cool down and long-term storage in liquid nitrogen or above liquid nitrogen if we're talking about ITS, which is intermediate temperature storage. Now, if we're looking at kind of high-level variations of different people do different things, different teams, different organizations do different things, I think that they're like on a very high level, there are three main differences or four main differences where different teams, different organizations do things differently. So first of all, you can either remotely, standby, everybody does, every good organization does, stabilization, everybody does. And now the question is, do you do field washout or field cryoprotection? Field washout means you would just take out the blood and replace the blood against an organ preservation solution, but you would not go lower than 0 degrees Celsius. In fact, you would keep the body on water ice, so around 4 degrees, because you have not yet given a cryoprotective agent, meaning you cannot cool down to freezing temperatures yet. The other option is that you do what is called field cryoprotection. It's not field cryopreservation, it's field cryoprotection. So where you would not only replace the whole blood against a washout solution, you would replace the whole blood in the water in the body against a cryoprotective agent. And in that case, you then can cool down. Usually you can't do it to cryogenic temperatures, so not to negative 196 in the field, just for logistical reasons, even though we and others are thinking about that and working on that as well. But in most cases, the cool down is being done to dry ice temperature, which is around negative 80 degrees. And at that point, you already have depressed the metabolic activity so much that you can now transport the body safe and sound to the organization, to the next cryopreservation organization, without much additional damage. The second kind of consideration is what part do you actually perfuse and what part is actually being kept. So of course there's whole body cryopreservation, right? That's what we do primarily. There's what is called neuropreservation, which is just the head is being preserved. And last but not least, there's the option to just do brain preservation. We only offer whole body or brain. We do not offer neuropreservation for a variety of reasons that we're going to discuss in one of our next webinars. The second kind of consideration is what kind of cryoprotective agent is being used. For cryonics cases, for human cases, the most commonly used ones is either VM1 or M22. Mostly M22 is used by Alcor, and VM1 is used by Cryonics Institute. We use a variety of VM1. We're also very open to using M22. We're a bit, we're agnostic to that, which cryoprotective agent to use. In fact, what you will see, one of our research directions is to, depending on the specific protocol and depending on ischemic time, decide which procedure, including which cryoprotective agent we will use, which not only includes these two cryoprotective agents, but might also include so-called vitrifixation, which is a combination of vitrification, that is the procedure that is being done with these cryoprotective agents, and a fixative, basically a chemical fixation, to, under certain circumstances, change to that method, which might give advantages. And then last but not least, and that will not so much be discussed today, that will be in our next webinar when it's about long-term storage, is what kind of storage solution. Once you now have arrived, all the SST part is done, what happens now in the long-term storage facility? How is the patient stored long-term? And there are pretty much two big options. One is immersion storage, which means storage at negative 196 in liquid nitrogen. So it's a huge dewar. The dewar is filled with liquid nitrogen. The patient is stored in liquid nitrogen. And the other option, which is currently being developed, probably we will be the first organization which offers that option for whole body patients, which is called ITS, intermediate temperature storage. In that case, the patient is not immersed in liquid nitrogen, but stored in the gas phase above liquid nitrogen at a temperature that is slightly higher than negative 196, around negative 140, which in fact gives higher storage quality. And the reason for that is that at that temperature there's less thermal stress, meaning there's less fracturing, which is a risk, not a certainty, but a risk at lower temperatures, and actually in most cases happens to some degree, and that you can reduce, not necessarily 100% stop, but reduce if you just cool down to negative 140 degrees. So these are kind of the main varieties. We're mostly talking today about the first two, and the second variation about storage will be mostly covered in next week's webinar. Sorry, not next week, maybe in 2 weeks, or if everybody votes to do it next week, then we might also do it next week. So let's step one step back and talk about what are the goals about SST, right? SST means standby, stabilization, and transport. And all of these three things basically have different goals, right? Standby, very clearly, I already mentioned it, has the goal of making sure that if the patient is, or the second after the patient is pronounced, that the team is already on site, the team is prepared, the team has talked to the family, to the doctors, has organized all the logistics on site, so that at the second the patient is legally pronounced dead, the cryopreservation team can immediately take over and do everything that needs to be done to lead to have a high quality cryopreservation in the end. Now, stabilization is kind of the summary word of these procedures that need to be done or are done to then in the end have a high quality preservation. So most of the talk today will be about these stabilization procedures. So the goal of stabilization is to, at any point in the whole procedure, and of course this is not exactly the goal, but this is kind of how we think about it and how I think it should be thought about it. If at any point during the procedure you would stop the procedure and would like to revive the patient, then that would be possible. So you treat the patient through the whole process as if you could at any point revive them. So you want to give enough metabolic support that there's no further damage during the whole procedure than there was already the second you took over from the attending doctors. That's the long term, or that's the goal of the stabilization part. And last but not least, as I said already, transport, relatively simple compared to the other two. It's just transporting the patient as quick as possible without any delay to an organization, to a long-term storage facility for long-term storage. Probably in the future, transportation might be a bit more complex as well if you don't do transport on dry ice, but if you would like to do it at cryogenic temperatures, which actually has advantages. The main advantage here being that if you keep a body too long on dry ice temperatures, then ice crystals grow. Right? So -80 is unfortunately not a great temperature to keep cryopreserved bodies for long term, due to the fact that there's a lot of ice crystal growth at that temperature. So it would be much better to cool down to cryogenic temperatures, meaning lower than around -130 degrees, which is logistically quite difficult, but would be advantageous. And of course, one of the reasons why we currently only cover Europe is because then you don't have planes, you don't have the complexity of needing to fly a patient to another country, but you can just drive in one of the ambulance while you still do the procedure, while you still do the cooling, and then hopefully arrive at a facility without much delay and without having the patient for too long at dry ice temperature. Now, this is kind of like a visual representation why standby is so important. So this is a so-called an isotemporal or something like that driving map around Berlin. Basically, all these different shaded color areas represent how many hours you need to drive from Berlin, where one of our teams is located. So the reddish area here is 1 hour, and then the next area is 2, 3, and 4 hours of driving. So as you can see, within 4 hours of driving, you barely cover most of Germany, right? So that's why we have multiple teams all over Europe, while we're building more teams all over Europe, while we're collaborating or more and more working on collaborations with local teams to do this initial cool down. This, of course, like these fast driving maps, or how fast can you drive, that is mostly important for if we're being notified last minute, right? If we are being notified that someone has just died. That, of course, is absolutely not how we would like to have it. We would like to be told that someone might die. Even tell us weeks before, right? As early as possible, so that we can then dispatch a team, at least days before, to make sure that we are around once the person is pronounced. So in most cases, hopefully that is not required, driving fast somewhere or something like that. But of course, it can happen if we're being notified late. For this reason, we don't only have an ambulance. So this is kind of these driving maps that you see here is for the ambulance. We also have an SUV that can drive much faster than an ambulance can. And last but not least, if the patient is somewhere far away, we would of course fly, but that of course depends on the time of day, if there's a flight available. Otherwise, in most cases, we do a combination. So part of the team flies, part of the team takes the SUV to basically, be there as quick as possible. In Europe, and at least in Germany, you can drive pretty fast. And if there's a speeding fine, then that so be it. And then the ambulance comes as quick as it can to then have the full team there, ideally days before the patient is pronounced. Right. So just to give you a bit of an overview of how our teams are currently located, Berlin, Zurich, and the Netherlands is kind of our core. What is not yet shown, that in all of these European countries that are shaded here in blue, in all of them, maybe not all of them, but 90% of them, we're currently either have local teams set up, we're building local teams, we're training local teams, or we're in talks with local people to set up local teams, always to do what we, in a few slides ago, called first aid. So this initial response, and I'll show you in a second what that entails. Currently, we're not accepting members yet from the US or anywhere else around the world, mostly due to the fact that, in the US, there are some other organizations which we could contract with, right? But for the rest of the world, if someone dies, let's say in Brazil or in South Korea or in Japan or wherever, there's no way of how we would be able to be there fast. So those people who are interested in signing up for cryopreservation, those would need to plan for the time being. It's possible, and hopefully we will have teams there in the future. But for now, they would need to plan that should they be diagnosed with some terminal disease, that they would need to move to one of the countries that actually has teams on the site. Otherwise, their cryopreservation, the quality of cryopreservation would be so low that it's not advisable to do that. So those we would need to ask to, or currently are asking, to move to a country that has good coverage. We're currently in the process over this year and then next year to also set up teams in the US. Those will not cover the whole US, but practically speaking, these metropolitan areas around New York, around Miami, around Portland and Seattle, and around the Bay Area and San Francisco, to then cover these areas with teams, some of which we will partner with to have good coverage there as well. But our focus for the time being will be on Europe, building more teams here, expanding the coverage area more and more. So how does one of these response teams look, right? Usually it's a combination of trained people, doctors, perfusionists, and just trained people, trained in the procedures of cryopreservation, and some type of car. Instead of the car, there can also be so-called flight kits, which then can be taken on planes to then, if someone dies now in the south of Portugal or Spain, then with a car we takes quite a few hours to get there. If it's not in the middle of the night and there's a flight relatively soon, then it's of course beneficial to send one team via plane first, and then have the car-based teams follow. That's one of our ambulances. That's the one here based in Berlin. Berlin is also, as I said, outfitted with a fast response vehicle, which is practically speaking an SUV, and then also with flight kits that can be taken on planes. And kind of on the right, you see kind of a visual representation how then doing the standby and perfusion procedure in one of these ambulances looks. So when one of these teams arrives, right, either by plane, this is for example here one of these plane kits or first aid kits, then you would always start with stabilization. Stabilization basically means putting water on the body, starting with chest compressions and giving oxygen and giving medication. So in that kit here, that can be taken on a plane or even can be given to local volunteers. That is what that initial kit is for. Of course, the ambulance and the fast response vehicle are outfitted with similar, looking slightly different, at least for the oxygen part, but pretty much the same. Those kits are also, of course, in the cars. But that is one of the kits that would be taken on the plane. So initially, you want to cool down. And you want to cool down with a variety of methods. Practically, you want to use any type of surface area that you can find in or around the body to do cooling. So the most common thing is to put a lot of ice on the body and then put a lot of water. Basically create a slurry. The water is there to have large surface area, right? If you just has ice cubes, there might be one ice cube here and here and here and here. But to increase the surface area of that ice, you want to put water. And you want to now flow the water around the body, right? So to always remove the warm water on the skin, the water would warm up. So you want to move that away to replace with cold water and mix around the cold water with the water that heats up on the surface of the body for the best cooling effect. So in our case, you see here on the right this kind of white box-like looking thing. It's again in the ambulance at one of our trainings. That's the so-called ice bath. It's basically an operation table with walls where you can put a lot of water and then flow this water with a pump system around the body. In addition to flowing the water around, you also spray the water around the head. You see in blue here around the face of this dummy, a so-called cool down mask, which is basically connected to a pump and flows water around the head to give additional cooling efficiency to the head. And of course, in turn, to the brain. In our case, we also cool with a range of different methods, some of which have been done in the past. Currently, I'm not aware that any other team does them, even though I might be mistaken there. But at least in our belief, this makes a lot of sense. So, what we use in this cooldown mask, you don't see it here on the picture. There's an additional outlet, or actually two outlets, that connects to the nose. So behind the nose here, there's the so-called nasopharyngeal space, which basically, that's the space if you have a bad cold that fills up and hurts and so on. So it's all basically here behind the nose and behind the large part of the face, which has a reasonable amount of surface area and is pretty close to the brain, which you can then flow waters through to have additional cooling. We also use the torso, the area around in the stomach, the so-called I don't know what the English pronunciation is, peritoneal space. That's the answer. So you do what is called peritoneal lavage, where you put cold water basically in the stomach space, not into the stomach, but into the space around the stomach, and then flow this cold water in and out, in and out, in and out, always replacing against cold water, of course, cold saline in fact, to use that space for more cooling. And then, of course, once the perfusion system is attached to the body, right, then you use the whole vasculature, the whole blood vessel system for internal cooling, which, of course, has a significantly higher surface area because there's a lot of small blood vessels everywhere. And of course, the brain is very well vascular, has a very a lot of vasculature, which gives a significantly faster cooling rate than just cooling on the outside. And last but not least, a technique that is currently being developed and actually has been in development for a good amount of time, but now there's a new push to develop it, which is called liquid ventilation, where you basically use the lung space, the lungs. You fill the lungs with a certain type of liquid and then flow that around to use the lung for additional cool down surface basically. And of course, none of these things is an either or. In fact, you want to do all of those at the same time or as quick as possible to have the best possible cooling rate for a patient who has, hopefully just died and you are able to take over at 37 degrees Celsius body temperature, and then you want to cool down as quick as possible to 0 degrees. Now, cool down is the first step. Now, once you've cooled down a bit, at some point the cooling efficiency of the outside and even peritoneal lavage and nasopharyngeal space and so on is not really the cooling rate just diminishes. At that point, you want to not only due to that, but also since you want to now give cryoprotective agent before you go lower than 0 degrees Celsius, you want to cannulate and perfuse a cryoprotective agent, first a washout solution and then a cryoprotective agent through the vasculature. Here on the picture, you see one of our perfusion circuits, one of our perfusion systems that is being used in the ambulance. There's also one that can be transported on a plane, and of course there's one, a stationary one at the facility in Switzerland. So that initially would also perfuse pre-cooled solutions through the vasculature of the body, which gives a very, very strong cooling effect. And of course, now before you cross 0 degrees, I already said it, you need to make sure that you have a high concentration of cryoprotective agent in. You basically start with low concentrations and then increase the concentrations in step-by-steps. And before you go under 0 degrees, you want to have a cryoprotective agent concentration that avoids ice crystal formation, which of course is the primary use of the cryoprotective agent. So that's the second step. You don't do that immediately. The reason is why you don't do this immediately is because if you get a body, right, and you do chest compressions and you give oxygen and so on, then there is some amount of oxygen supply to the brain. So the cells get enough oxygen to not die. If you would start directly with perfusion is a surgery. It's a surgical step. So in our case, we do median stenotomy, meaning we open the chest and then cannulate the heart. I'll show you where and how that works in a second. But if you do that, you would need to start chest compression. You would stop chest compression just because you need the chest for the operation. So the effect or the negative effects of stopping chest compressions are in most cases larger than the positive effects of getting on bypass, on connecting a heart-lung machine as quick as possible. If your medical teams, if your surgical teams are very, very, very fast with cannulating, then it might be possible, or it is possible, to do less chest compression, less initial cooling, and switch over to internal perfusion-based cooling quicker. But it really depends on the speed of your surgical team. Now, I already said that we do median stenotomy. Right here on the right, you see a representation of the vasculature of a body. In our case, you see 3 dots. 3 dots are kind of, by and large, the main cannulation points of where you can get access to the circulatory system and where you can perfuse large amounts of liquid. So one, I already mentioned, is the chest. You would open the chest and then there's the heart, and the main vessel of the body, the aorta, is connects to the heart, and you would cannulate that aorta. That is basically what is being done in surgical theaters in a hospital, where you would put a patient on bypass to do any type of heart surgery and so on. They cannulate the ascending aorta. The picture is that under certain circumstances they only supply part of the brain, because there's 2 vessels here and there's 2 vessels basically on the spinal column on the neck, and technically cannulate both. And then you can also do a femoral cannulation. Basically here on the leg you see another, but you see a part that is highlighted in pink. There's basically a circle, the so-called circle of Willis, in the brain where all the vessels connect, on both sides, right? That on the front, it's being supplied by the 2 carotid arteries, and on the back it's being supplied by the vertebral arteries. Now, in young people, or if there's no problems with that vasculature, then everything is fine, right? Then you can just supply here, and since this vessel, the circle connects everything to everything, if you just cannulate here, or even one side, technically, everything would be perfused. The problem is, most cryopreservations are being done in people who are not young. They're relatively, let's say 85 or somewhere in that range. In that case, this circle of Willis can be occluded. It can have, parts where no flow or very little flow goes through. So in that case, it's not sufficient anymore to either cannulate here, but because if it would go up, but then if the part that supplies the rest of the brain, that is usually directly supplied by the vertebral arteries, would not get cryoprotective agent and would not be cooled down quick enough. So vertebrals, the carotids, everything that goes up connects to the aorta. So that's why we have decided to go for aortic cannulation, because it's just nothing can go wrong. You don't need to know the anatomy. You don't need to understand if there might be some occlusion, and so on and so on. And in at least our opinion, it's also just easier to cannulate, even though it might be a bit more graphic, because you need to do median stenotomy, you need to open the chest. It is from a cannulation standpoint either equal or easier. Right. Then going to the next part, which is monitoring, right? So while this whole procedure goes on, a lot of monitoring needs to be done. And for different steps of the procedure, different types of monitoring is required. And while the procedure is being done with high quality, and then in the end, the cryopreservation procedure of the patient is high quality, which in turn increases the probability of if and when revival will be possible. So if we go from the top, so the first kind of quality metric is what is called end tidal CO2. On the right here, which is a patient monitor, you see basically it's the yellow curve, the yellow area on the bottom. So end tidal CO2 means if you breathe in and out. At the time when you breathe out, CO2 is coming out. That is what our lungs are doing, right? They're taking oxygen in and take CO2 out of the body. End tidal CO2, even though it's a bit of a weird name, means in one of these curves, what is the highest point of CO2? How much CO2 can the body push out? Now, if you do chest compressions, if there's no circulation and the lungs don't work because the patient has died, then you get, when you do chest compression and you give oxygen, you use end tidal CO2 as a measurement of how well do you give chest compressions and how well do you give oxygen support do you give. So you want to have an end tidal CO2 that is as close as possible to as it should be if the patient would be alive, which is not always possible, but that's the goal. That's the goal that SST teams should strive for. The second part, of course, you do a lot of temperature probes. You have multiple temperature locations. You can do rectal temperature. You can do nasopharyngeal temperature. In our case, we don't do that because we use that space for cooling in the ears and so on. So you have multiple temperature probes to make sure that you have an understanding how fast you cool down, and make sure that you later on know that you have cooled down fast enough. Then during perfusion, the most important factor is pressure. Pressure means you don't want to perfuse at too high pressures, right? The body is used to a certain pressure, like everybody, if you just measure your blood pressure, you want to perfuse at around that pressure. That is a big difference of how in hospitals perfusion is being controlled. They mostly control perfusion circuits with heart-lung machines with flow. They just look at there's enough flow rate. But in our case, since the cryoprotective agents have different viscosity, right? Low concentrations have lower viscosities, high concentrations have high viscosity, meaning they're very thick fluids. So in that case, whenever you change to a new cryopreservation, once you increase the temperature, right? Once you go over to the next concentration of cryoprotective agent, you need to make sure that you reduce flow rate to keep the pressure at the level where you want to be, right? Which is at max around 120 millimeters of Hg, which is kind of what you're supposed to have, what your blood pressure is supposed to be. Now, these three things, while the SST procedure is going on, are by far the most important factors. And now there's a few others that we have implemented. Again, I'm not sure if anybody else does that, but I think they make sense. One would be, we're testing that, which is cerebral oximetry, where some of you who might have been in the hospital got one of these finger sensors that measures basically how much oxygen is there in the blood, right? You can do that in the brain as well. So you basically have two probes here and on the forehead, which measures how much oxygen gets to the blood. So that's for us another measurement similar to end tidal CO2 from a use case to measure if our stabilization procedures, giving oxygen, doing chest compressions, if that works well. Last but not least, taking samples, basically from the fluid that flows out of the body, right? You put cryoprotective agent in, and then blood, and then later on also low concentrations of cryoprotective agent come out of the body. So we're taking at intervals, we're taking samples there to potentially later on get some data from these samples, even though there is no highly important reason why you want to do that, right? Why you want to do that, you cannot really do. You don't really change your procedures based on these samples. but it's good to have them. One thing that you do with these samples is you measure what is called a refractive index. Refractive index is a measurement of how high the concentration of the cryoprotective agent is that comes out of the body, right? So it measures if the cryoprotective agent concentration that you put in has already equalized through the body, and then the same concentration comes out. It's a measurement, so that's what you use these samples for. It's a measurement, or it's a value, how you control when to stop with perfusion and how well your perfusion is going. And then after the procedure, based on these values, based on temperature values and so on, you can calculate a value which is called S-mix, which is the standardized measurement of ischemic exposure, which is basically a calculatory value that kind of compares how much ischemia have you generated during the whole procedure, and basically it measures how long was the body at a certain temperature and where chest compression is being done. So it gives one value which gives you a high-level understanding of the team did. And last but not least, there's maybe a couple more. The last important one is CT scanning. So after the patient, most importantly, the brain should be CT scanned to see in the CT if there's ice formation. Where there's ice formation, how much is there ice formation, and so on, which is kind of like the ultimate factor or the ultimate metric of how well the perfusion and the whole procedure went. And you can see two things. First of all, you can see the ice with patients. It's more done in scientific body donors who just donate their body for science but don't actually want to be cryopreserved. You can also do biopsies where you take a small part of the brain tissue to then check into electron microscope if there's ultrastructure, if there's good ultrastructure preservation and so on. But that is not being done in a standard cryopreservation case, because of course it would be very invasive. Right, so that's monitoring, and then to leave enough time for questions, just to kind of give a bit of an outlook of what is being currently talked about, currently being researched by us and other organizations, and then hopefully soon implemented. One would be so-called blood-brain barrier openers. So it's important to understand the brain kind of works differently in regards to vasculature than the rest of the body. So all the vessels of the brain have a very strong kind of layer, the so-called blood-brain barrier. It's mostly there that no bacteria or anything that's not supposed to go into the brain, the body really protects the brain well, gets into the brain. In our case, it is not advantageous because it also stops cryoprotective agent from getting into the brain. Of course, we want to have it in the brain. Now, the blood-brain barrier, over time, if there's no oxygen, if there's ischemia, breaks down. So if there's much delay in the case, you don't need to use these blood-brain barrier openers. But if you're able, and of course that's what we strive for, if you take over a body immediately after circulatory arrest and of course legal pronouncement and directly start with the procedure, and then very quickly also with perfusion, the blood-brain barrier would stop cryoprotective agents from getting into the brain well. It's not a full stop, but it reduces the efficiency how these cryoprotective agents get into the brain. So in that case, you want to use so-called blood-brain barrier openers to open the blood-brain barrier and let these cryoprotective agents into the brain. Second point would be liquid ventilation. I already mentioned it. It's a relatively complex technology, but it uses the lung surface for further cool down. And if it works, it might lead to significantly faster cooling rates. So it's a very interesting technology, but it's not that easy to implement and might take a while until it's production ready in quotation marks. Then things that we think about a lot is fast cannulation techniques. So as I said before, the cooling with the heart-lung machine is very, very fast. So once you have the patient on a perfusion system and you circulate cooled down cryoprotective agent or cooled down washout solution through the body, the cooling rate is really, really good. You just can't do that early because, you don't want to lose the chest compression effect. If you would be able to do the cannulation, so putting the patient on on bypass onto the heart-lung machine, if you would be able to do this very, very fast, you could do it earlier. So we're researching a range of techniques, basically surgical techniques, how to do that very, very fast. And we're getting relatively good, but so there can still be a good amount of improvement. Then there's a lot of research into unified data loggers. I said there's a lot of data, a lot of monitoring devices. They're all individual devices. Just logistically, it's kind of annoying to handle all of them. Some of them are not that great. They're not that robust. So a couple of organizations, us included, are building basically devices from scratch that monitor all the relevant parameters in one box. Kind of similar how you would in a hospital. You have a patient monitor that monitors all the important vitals in one box. But of course, in our case, we need pressure and so on, things that the patient monitors don't have. It would be the same general idea, but optimized for cryopreservation. Then we're still thinking about more cooling methods. Just as peritoneal lavage would be one. How can you cool faster? What additional surfaces can you use for cooling? Then one would be large-scale craniotomy. So in some cases, during perfusion, there's intracranial pressure. Basically, the pressure in the skull around the brain basically increases, which on one hand damages the brain, and on the other hand, it also decreases how well perfusion works. So what you could do is, or what we're researching to do is taking large parts of the skull away, just like you would in some operations, right? You can also take relatively large parts of the skull with the skull off, of course without damaging the brain, to be able to then release that type of pressure. And I also mentioned it before, we're kind of very much working on these optimized protocols based on how much ischemia there is already, right? You probably want to, in cases where you get the body very, very quick and there's very little ischemia, you want to do protocol 1. If there is already a lot of ischemia, for example, because the hospital has not released the body in time, or we would be notified very late, and then we can only arrive just logistically, we would only be arriving, let's say, a few hours later. In those cases, you would probably want to use different protocols, and these are being researched. And that's not really a research topic, it's more like an organizational, logistical improvement topic. We're very much working on combining. Wherever a patient dies in Europe, we immediately have at least a team that can do initial. Right, so this is the kind of short-ish overview of procedures in SST. Just as an announcement, on April 20th, if we're not seeing later on a lot of votes to move this up on a weekly basis, then it would already be next week. Otherwise, for now, it's scheduled for April 20th. We will talk about long-term storage, organizational stability, everything that would be important once you have actually arrived at the facility, including cool down and all the stuff, and different storage methods like immersion and ITS that I briefly already mentioned. All of that would be in our next webinar. And very important, and I always can't stress that enough, if you're interested in the topic, we're more than happy to talk to you, to discuss with you. Of course, if you want to sign up, feel free to reach out as well. Don't hesitate, even if you just want to discuss a couple of questions, reach out to us either by email or by telephone, or we have on our webpage basically a form to schedule talks with us, to schedule consultations with us. Of course, they're totally non-committal, totally free, of course, as well. Don't hesitate to reach out and just discuss with us or with me. Last but not least, put all your questions into either the Slido or into the YouTube chat. And now we would go on to do all the Q&A and answer all questions and every question that you might have. All right. If not, when do you believe Tomorrow Bio will preserve their first patients in their facility? Yes, so active, we don't have any active cases, right now as an active case, but of course we had cases. So there's two types of cases that we've been doing. One is cases from our members. Statistically, there weren't that many yet, but some, and they're stored in the facility already in Switzerland. And the other type of cases is basically body donor cases. So The reason why we do these body donors cases, and those are people who, they don't want to be cryopreserved or they don't care about it, they just donate their body to science. We do a lot of those cases because wherever you are in the world, doesn't even need to be Europe, also in the US, it doesn't matter where you are. Nowhere in the world are enough cryopreservation cases from people who have signed up for cryopreservation to sufficiently train medical teams. Even one team you might not be able to train well, right? You always need to remember that worldwide, currently there are somewhere around 20 cryopreservation cases per year, all organizations combined, right? There might be years where it's a bit higher, there might be years where it's a bit lower, but it's somewhere in that ballpark. That is nowhere enough to train teams. Medicine is a very much experience business, right? So you need to have seen all the eventualities. You need to have seen different, details of how the heart looks and how the heart works. Not really works. It works pretty similar, but there's a lot of this detailed knowledge that you can only get with experience. So in our case, we kind of have these two types of cases. Of course, we have real life cases, but the number there is not high yet. We're always releasing once a year a review of all the cases that we had in that year. And the training cases are basically body donor cases of people who just donate their body to science. Next question would be, do people often sign up together with family members? So unfortunately, much less than I would hope. The reason for that is usually there are some families, where the whole family is totally down with cryo. There's one person who is interested in cryopreservation, and everybody else is either not yet, hasn't thought about it enough to have made a decision, or is neutral to it, or is even not interested. Right. So, of course, in our case, we're more than happy to have families. In fact, if more people from one family sign up, we give them a discount to kind of incentivize that a bit. But talk to all your families, and if they're not yet signed up, try to inform them about it. Convince, I feel like is maybe the wrong word, but try to inform them about it and make they're interested in signing up. And of course, if they're open to it, we have a cryopreservation kind of system, so you could pay for them. Of course, they still need to agree and understand what they're signing up for, but you could pay for them. And if someone wants to have a call together with a family member with us, then of course we're also more than happy to do that, to kind of give them our side of, or inform them from our side of the equation. Next question would be, is family allowed to stay in the room during the first stages of the procedure? No, unfortunately not. First of all, the procedure is usually done in one of our ambulances, which is quite tight, there isn't much room. And also, just like family members are not allowed to stay in an operation room during a major operation, it's not really because of being sterility or anything like that. It's a stressful situation for the family members, but also for the team. It's a situation where a lot of concentration is required, and any type of distraction would not be helpful. So that's unfortunately not possible. Next question would be, how did your first cryopreservation case go? So the cryopreservation case, I don't know what the question. Oh yeah, okay. How did the first cryopreservation case go? So we will basically we will release full reports every year, where then all cases are summarized. The case went well. The case is now in long-term storage in Switzerland, and that is these are the real cases, right? There are no real reports for the body donation cases, but for real cases there will always be a comprehensive report at the end of the year, which then shows all quality metrics and outcome metrics and so on, to give everybody an understanding of how well the cases went. Next question would be, can the long-term cryonics care optimal temperature, perhaps about negative 140 degrees Celsius, be made cost-effective for those of limited means? So the question basically asks about ITS versus immersion storage at negative 196. The storage at 140 is indeed as much as we understand, better. It doesn't lead to this fracturing. It doesn't lead to that thermal stress. So in that case, the dewar would not be filled fully with liquid nitrogen, but just on the bottom. And then there's a variety of mechanisms to reduce the temperature gradient in the dewar. The problem there is that the dewars are significantly more expensive, and the day-to-day usage of liquid nitrogen is also higher, meaning it makes it more expensive. So for now, once we get the first ITS dewar, which currently is being developed and engineered and built, once we get that, probably ITS would be significantly more expensive than immersion storage. We hope that we can bring those costs down, just like we hope that we and work on bringing the cost down for any case, any storage. That larger dewars, having more people go into cryo storage. That would probably take a while. So for now, unfortunately, that will be significantly more expensive. If someone is open to it, brain preservation at ITS temperatures would probably be then, again, maybe slightly more expensive than brain preservation in an immersion dewar, but significantly, probably the difference would be less. That might be an option. Next would be, please discuss the chemical fixation versus cryogenic preservation issue. So there's kind of three different types of preservation, right? When you talk about cryonics or cryopreservation, most of the field what is currently being employed is cryopreservation, which means vitrification, where you basically use cryoprotective agents and then cool down, and then they go through what is called through the glass transition temperature, meaning glass transition, it goes into a vitrified state, which is then glass-like. That is what most of the field currently does. That is where most experience is. Now there are two other types of preservation. One is called ASC, aldehyde stabilized cryopreservation, which is a combination of chemical fixation and cryopreservation. In the lab, there has been pretty good data about that, showing good ultrastructure preservation and so on. So there's good data about it. And last but not least, there would also be the option of just doing chemical fixation. All of these options has different upsides and downsides. So under very good conditions, aldehyde stabilized cryopreservation leads to good results, right? Well established, good published results. Vitrification probably also leads to good results under ideal circumstances. There's just less data published about it, but more like practical knowledge. So on the other hand, under not so great circumstances, ASC becomes very difficult. Vitrification still works maybe better. Under, on the other hand, very bad circumstances, meaning you only get the body, let's say the hospital doesn't give the body out or something like that, like logistical problems that are a bit outside the control of the organization, or they're being called very late. During those stages, probably ASC doesn't really work anymore. Vitrification is probably not great anymore. So at that point, you might want to do chemical fixation, but not chemical fixation with perfusion, but chemical fixation with immersion, diffusion. So you would put the body or the brain into basically this chemical and it would diffuse in. So long story short, the topic is pretty complex. When I said before how you want to adapt the protocol to different circumstances, that is that. In some cases, you probably want to do pure vitrification, and some you might want to do immersion fixation and so on. So it really depends on the circumstance, and it also depends to a degree on some almost philosophical issues where some people might not be interested in chemical fixation, whereas vitrification would be open to it, and so on. And of course, this is a bit of an informed consent issue. So for us, it's always very important that people understand what they're signing up for. So that would be a discussion that needs to be had on an individual basis, and kind of explained what are the pros and cons of these different versions. Yeah. If you have a specific follow-up question about that topic, let me know. And by the way, if I don't answer any of the questions comprehensively, and if you have follow-up questions, please always post them in, and I'll do them at the end. Just for this topic, it's you know, you can talk a long time about it because it's pretty. There's a lot of differences and a lot of upsides and downsides. Next question would be: should we use the term long-term care of patients rather than the term storage? Yeah, probably. The problem is long-term care kind of sounds like it sounds like a hospice or like a retirement home, which of course, so on the other, you have some other problems with that. I don't like the word storage either. So I think long-term care, sometimes I think we use on the webpage long-term care / storage to kind of, split the issue a bit. I'm not aware of any great word that on one hand explains it and on the other hand is not, kind of confusable with something else. Because we always need to remember, we're also not only talking to people within the community, we're also talking about the broader, population, right? And if they hear long-term care, it might sound more like a hospice or like a retirement home to them. So I don't think this word is great, but I also don't have a better one as of yet. Next question would be, what are the pros and cons of your SST procedure, or what other cryonics organizations do? So I think field washout opposed to field cryoprotection doesn't really have any advantage, except for maybe one case, or one situation. If you're very, very close, so basically the procedure is like that, yeah, right? The person is pronounced, you take over, you do stabilization, and then at some point you start with perfusion, and then at some point you reach the facility. If you are at the right distance from the facility, where it makes sense to do the washout on the way, but then before you want to start perfusion of cryoprotective agent, you're already at the facility. At that case, field washout would make sense. But in that case, we also do field washout, right? If we at that point just arrive at the facility, then of course we switch over to the facility equipment because it's a bit, there's more room, it's easier to control and so on. In all other cases, I'm not aware of any advantage of field washout as opposed to field cryoprotection. That can be discussed. Maybe other people have other opinions, but I'm not aware of any real advantage of field washout. In fact, it's quite the opposite. It would be nice if you could do field cryopreservation, meaning you do the whole perfusion and then the cool down to cryogenic temperatures, so around -130 at the minimum, in the field, and then transport at cryogenic temperatures. Logistically, that's quite difficult, so no one does that currently, but at least it's something to think about. That might be something, that is worthwhile to discuss. All right, next question would be, can the long-term cryonics care optimal temperature that we already had? So if that can be made, cost efficient. Next question would be, relative to cryonic hibernation, please discuss the blood-brain barrier and brain shrinkage. So just as a heads up, hibernation is not really the right word. It's more like cryogenic, cryogenic storage or long-term storage. But just a side note. So blood-brain barrier openers and brain shrinkage. So currently, if you don't use blood-brain barrier openers, the cryoprotective agent does not get into outside the vessels well. What does get outside the cell, so this cryoprotective agent has a high osmolarity. So high osmolarity means there's a lot of particles, in simple words, a lot of particles in it. In cellular fluid exchange, what happens is that the particles don't move around, the water moves around for osmolarity. So what happens is that there's a highly concentrated solution in the vessel, and the water is being drawn out of the tissue into the vessel and then out of the body. If you do that, so meaning the cryoprotective agent, this highly concentrated solution, doesn't get well into the tissue, the water goes out and is being then, outside of the body. In that case, since you reduce now the amount of water in the brain shrinks. So currently, if you do a CT scan, the fact that the brain has shrunken is a metric of quality. Shrinkage means good cryopreservation, meaning that there's no ice, that the water is all being replaced and there is no ice. In the future, it should be done that you use these blood-brain barrier openers, meaning this cryoprotective agent would go into the tissue better than it currently does. You would have less shrinkage without ice formation. So in the future, in a CT scan, the quality metric would be no shrinkage and no ice formation. Currently, you basically either have shrinkage and no ice formation, or you have no shrinkage and ice formation. In the future, it would be no shrinkage, no ice formation. And if you want to have more details, let me know. But again, that's a pretty complex topic. Next question would be, do you think future rejuvenation technology will be able to overcome the fracturing cracking problem? So maybe not rejuvenation technology, but there was recently a book released from Robert Freyes called Cryostasis Revival, which is a very, very extensive book. You can find it online. It's a free PDF. You can also buy a hard copy on Amazon. Robert Freyes, Cryostasis Revival, if I'm not mistaken, which is a very extensive, like 700-page, highly technical book that explains what would need to be done for revival. And including all the repair and all of that. The fracturing issue, where basically due to this thermal stress you have macroscopic fractures, in his explanation, in his opinion and his analysis, is less of a problem than other types of damage. So most likely that would not be that much as we currently at least understand, would be that much of an issue. Yeah. How can you solve the problem of fast response? I'm in the south of Europe, a bit far from Berlin. Absolutely. So fast response worldwide is indeed a big issue. So in a standard case, we want to be around where you are, right? So let's say you're being diagnosed with terminal cancer or some other disease that might lead to your death, like terminal disease. In that case, we would dispatch our team. The team would bring all the equipment, including the ambulance and whatever. Let's say you're in the south of Europe. Let's say you're in Barcelona or Madrid or in Lisbon. We would then wait there, even if it takes All right, back again. Yeah, so last but not least, I was just saying I would recommend whole body as opposed to brain preservation. Next question would be, would you use the term vitrification rather than the term freezing? Absolutely. Freezing is just a wrong term. Like everything we do is to not freeze anything, right? The only problem with the term vitrification is that vitrification is kind of like, it's the word that most people don't use, or either have never used before, which is probably the most likely case, or don't use regularly. So whenever we give interviews and so on, then the journalists always put the headline something with freezing. Of course, we don't use this word ever, since it's just technically not the word that that is correct. Is cryopreservation available for people in the UK? Yes, it is. So we do cover all of Europe. We plan to have teams everywhere, including the UK. For now, initially they're going to be local, even volunteer teams, but later on it's supposed to be everywhere. So even you can sign up right now in the UK. Feel free to reach out and we can discuss how it works and how everything, what needs to be done to sign up. Is your ambulance allowed to drive faster through traffic like normal ambulances are? No, it is not. It's not an ambulance technically. It's an ambulance from the outside, but it's not registered as a medical ambulance anymore because it can't be. In most cases, that's not really a problem because the speed inside a city, where you're limited by traffic limits, speed limits, it's not that much of an issue if you're a bit slower for a cryopreservation case because you can't gain that much time anyway. It's more like from city to city where the difference is relevant. In that case, if it's a traffic fine, we might be open to just paying the traffic fine, and not might be, we are open to just paying the traffic fine. The traffic fine. Next question was, how is liquid drained from the cells? So liquid, I kind of experimentally drawn outside of the cells due to the cryoprotective agents and the fluids having higher osmolarity. And kind of looking a bit on the time, I'm going to speed up the questions a bit. And if anybody feels like I haven't answered their questions fully, please just reach out, send us an email. I'm more than happy to then, give you an answer in person. Are you hiring physicians, and what kind of specialty would you be looking for? And what kind of scientists are you looking for? Biologists, chemists, and so on. So we do have physician positions, and we actually have physicians on the team, apart from me. Rishi, some of you might have already met him or have seen him on our YouTube. From a specialty standpoint, there is nothing that is absolutely, well-fitting. Small advantage maybe for surgical specialties, but all in all, we're more than happy to train people from scratch. And in fact, that is actually required for cryopreservation because it's unique knowledge that it's not really, well-fitting to any specialty. Scientists, we're also looking for scientists. There it would be cryobiology, neuroscience. These would probably be the two main ones. Next question would be, sorry, already answered. How many people can you fit into cryo storage currently in Switzerland, assuming full body? So assuming full body, so Switzerland can have multiple extensions. Currently we can do around 400 to 500, but we can pretty easily, and so on, we can pretty easily expand to 1,500 or so. And once you're at that level, at that size, at that point you will have enough funds to just build another cryopreservation facility, a storage facility, wherever you want. Next question would be, what if I want to wake up from cryo with certain belongings, such as a hard drive with my family photos? Can I store them with me? Yes, you can. So everybody has a certain amount, a small amount, to be fair, of storage. We're soon going to open up a new type of membership, which we call legacy membership, which would exactly the same preservation quality, but then has add-ons like, for example, more storage space, probably a smartwatch that interacts with our app and so on. A few additional things, even though storage quality would be and preservation quality, there's no difference there, just add-ons. But even now already you can have a limited storage space in addition to the cryopreserved patient. Next question would be, I've done a DNA test. Would it be useful for you to have the data on my file? Probably minimally. So of course, so we would still have your cells, right? So for revival, for cryopreservation, we're not aware of any DNA markers that would have any impact on doing something during the preservation procedure. And in the future, of course, once you're being revived or once that technology exists, all your cells would still be there, right? So at that point, you would be able to get DNA. Of course, if let's say you're 95 at that point and you would have DNA from your 20s, there might be some advantage of having young DNA, even though that's very speculative. I can't say that this is for sure that would be advantageous, but it might be. Yeah. And now, if there's a few more questions on the YouTube chat, I'm not sure if I can see them here, because for whatever reason, maybe my team can tell me if there are questions on the YouTube chat. So I'm not 100% sure, but I don't see any questions on YouTube. Aha, now I see some questions. All right. Are you hiring physicians? We have answered that question. What about aldehyde stabilized fixation or stabilized cryopreservation? I kind of answered that, I think. Yes, we're familiar with it. We think it's a great technology. It's a bit more complex to implement into day-to-day, field cryoprotection, for example. Just logistically, and it is slightly more difficult to use under non-ideal circumstances, meaning if there's some amount of ischemia already, it's more difficult to do. Let's see if there's anything else, apart from a lot of comments about technical difficulties, which again today we had a few. There's one more question. Would the repair technology need to be so advanced, for example nanotechnology, that the kind of preservation wouldn't be a problem? Like you can apply the same advanced repair to chemo, cryo, mixed procedures. So there is a potential future where nanotechnology is so advanced that basically any type of damage that has been accumulated today would be fixable. Some scientists advocate for that, basically by arguing, listen, whatever the quality of cryopreservation it is, that will not matter, or it doesn't matter very little, it can be fixed in the future. I honestly don't like that opinion, because maybe they're right, but maybe they're also wrong, right? If we don't do the work right now, we will not be able to go back. Maybe it's possible that they're right, and I wake up and everybody else wakes up, and then someone tells us, listen, guys, you have over-prepared so much. You wouldn't even have needed to do all of that, right? And then I say, hey, that's fine. That's great, awesome, good to know. But I'd much rather much over-prepare than have the risk of under-preparing. Because it is possible that nanotechnology will fix it, but it's also possible that this advanced nanotechnology will not exist, or it will only exist much later, right? So I always think about these topics, how would I be rather wrong, right? If I over-prepare right now and I'm wrong, that's fine by me. If I under-prepare and I'm wrong, meaning the advanced nanotechnology does not exist and you then, for example, could not revive someone, yeah, I really don't like to have that happen. So due to that kind of, how you want to be wrong consideration, in my opinion, it is prudent to do everything we can to have the best possible preservation quality. And every case you do, you learn and you improve, and you do training cases, and you do body donors, and you just train your teams normally, like just without a body donor, just going through the motions, right? So that's why we do trainings, that's why we do body donors, that's why we have training dummies to do it on the dummies, right? Go through everything so much, improve, to then, well, if you're wrong, you're hopefully wrong by having over-prepared. So that's how we think about it. Okay, last chance, if there's any questions for now, you should put them into YouTube chat if there's any last-minute question. Otherwise, I would like to thank everybody for joining the webinar. And hopefully I see you next time. And without further ado, because I don't see any more questions, Thank you so much and have a great Easter weekend.